All right, so I think we have on the line our guest for the morning, Dr. Lisa Curcio. Good morning.
Good morning.
Thank you for calling in.
Thank you for having me. I'm excited to be here.
Anyway, let's see. So I'm pronouncing your name correctly, right, Curcio?
Yes, it is.
All right. So Dr. Curcio is new to our area. She is with the Nuvance organization, although I'm sure she and I will agree that we try to practice kind of take care of the entire population, or all the patients in our community as well. And that you are a surgeon, and more specifically a breast surgery specialist. Is that correct?
That's correct. I underwent additional training after general surgery as a surgical oncologist, which is a cancer surgeon, and a subspecialist in breast cancer surgery.
Okay. I always like to start the interview by just kind of asking you to tell us a little bit about yourself, how you wound up in Rhinebeck. I understand you relocated recently from California.
Yes, correct. So my route to Rhinebeck has been somewhat circuitous.
Okay.
I'm actually a native of northeastern Pennsylvania. Grew up in the Scranton-Wilkes-Barre area, and went to undergraduate school there. Then went on to go to medical school and residency at George Washington University in Washington, D.C. And then I went to California, where I did my surgical oncology fellowship at City of Hope in Duarte, California. From California, I actually had a health professions fellowship. The United States Air Force paid for medical school for me, and I paid back my obligation at Keesler Air Force Base in Biloxi, Mississippi. So I spent 4 years in Biloxi, Mississippi. Then returned to Southern California, where I spent about 19 years practicing surgery, and particularly over the past 15 years, breast surgery.
Okay. And the final chapter is how you wound up in Rhinebeck.
Yes, so I really wanted to get back close to my family. Mm-hmm. I was kind of the only wanderer so far away, and I decided when this opportunity came around to grow this program and to build the breast program, I really found it a great opportunity to do something meaningful and to get back closer to home.
Okay. And I thought you also chose to live in 9-degree weather over rather than the weather of Southern California.
The weather in Southern California is amazing. There's no doubt about that. But, it is Southern California.
All right. So how are things going so far now that you're here?
So I have to say that the support from administration at Northern Dutchess Hospital has been amazing. They have really invested in growing this program, including purchasing, I think it was like $250,000 worth of equipment to really bring our program, to state-of-the-art care. I think our biggest challenge is I joined the group in October in the middle of the pandemic. And so it's been, somewhat challenging getting the word out that we do have a breast program now at Northern Dutchess, because in the past, I think patients were referred out. And so we're really working on trying to make people aware of the fact that we do have a quality program at Northern Dutchess.
Okay. Well, I have my good friend, my special friend, Robin Baker, is also our co-host, and there she is. Say good morning, Robin.
Good morning, doctor.
Okay, and then Robin is here kind of to make sure we don't get too jargony in our discussion.
Patient perspective.
Yes.
Absolutely.
But a couple themes we have on the show, and I'm a primary care doctor, so we tend to talk a lot about prevention, and we also tend to talk a lot about evidence-based guidelines, and breast cancer is one of these topics that breast cancer screening prevention I have questions about. When I was in medical school and residency, the recommendation was for women to get a baseline mammogram at 35 and then start getting annual mammograms at 40. I still kind of do the 40 guideline, but I read I read and I understand that there are recommendations out there to recommend 50 and to recommend screenings every 2 years instead of every year. What's your take on that?
So I do believe you're not the only one in the medical profession that is confused. Because if you look at the guidelines from different societies, they're all over the board. And so it's really hard for patients to know what to do when the medical profession, different professions and different subspecialists are very kind of discontiguous on what the recommendations are. The American College of Surgeons the American Cancer Society recommends starting at least at age 45 with yearly mammograms, and they suggest that women should be given the opportunity between ages 40 to 45. And then the controversy becomes, should we go at age 50 to every other year? And that's what the task force seemed to recommend, that yearly wasn't needed and that every 2 years starting at age 50. Our society, the American Society of Breast Surgeons, still feels very strongly that we should start screening at age 40 and we should continue yearly screening moving forward. Another controversy that we see a lot is when to stop screening.
That's a good question.
And there are some organizations, including the task force, that recommend stopping at a certain age. But I think that as our population ages, and I think our population is aging better, I mean, they're healthier in their 80s and 90s, by stopping screening, say, at age 75, what that's allowing is these women to develop more advanced breast cancers that they feel and then be subjected to, things like chemotherapy and more radical surgery sometimes. So I think that a lot of the organizations are starting to say, you got to look at the overall health of the woman, what their comorbidities are, what their other medical problems are. And if they have a life expectancy of 10 years, they should be getting screening.
Okay, I feel kind of vindicated. In primary care, for example, the recommendation for screening colonoscopy, is kind of a hard stop at 75. And for breast cancer, it's individualized. And that is sort of the way I counsel my patients in their late 70s and 80s, particularly in the context of like a wellness visit. I really encourage people to have these regular visits with their healthcare provider, because this is the time to discuss these issues. Because as you very clearly made, there's no clear answer. It's an individualized decision on when a woman should stop getting mammograms.
Right. And I think you're correct, and it does have to be individualized, and patients should be educated. What are the benefits? What are the risks? And then they participate in a shared decision-making process.
Shared decision-making, yes. That is, again, this is part of what we talk about a lot. I had a couple other basic questions. What about the role of a breast self-exam? Again, it kind of makes sense, right? But then I read that certain sources say not to do it, which is a very peculiar recommendation, because it makes sense for somebody to check themselves. What do you think about that?
I absolutely agree that breast self-examinations are essentially important, particularly in the age group of women before their screening, because we do see women not uncommonly present with a self-detected breast mass. I think the American Cancer Society came out many years ago, discouraging breast self-examinations. And again, I think that was a grave disservice to women. I think knowing what your breast feels like and knowing if there's a change is just another part of being proactive and preventative in your overall health. And I strongly encourage breast self-examination.
All right. I think I kind of just jumped right into the topic of mammograms. And perhaps we should just kind of review for people what puts a woman at risk of breast cancer. What are some of the common areas that would make someone more concerned about the possibility?
Okay. So certainly, the big risk factors are being female and getting older for breast cancer. But if you're looking at what are the other things that can increase risk, are obviously family history. Women who have never had children or had their first live birth after the age of 40 are at increased risk. Women who have been on many years of hormone therapy are at increased risk. Women who have had biopsies that show atypical changes are at increased risk for breast cancer. And there is some data to suggest that women who continue to have dense breast tissue, particularly into menopause, may be at increased risk for breast cancer.
Okay. I remember a couple of years ago there was a lot of talk about breast cancer pockets, like particularly Long Island, for example. Is that something that that you recall, or is that something that's relevant?
So I think that you do see sometimes kind of clusters, and the question becomes whether that's just related to women that have similar demographics being in one area, or perhaps some exposure, women who grow up in a certain area, some kind of environmental exposure.
Right.
But I don't think we really understand the epidemiology when we see clusters like that. I think it needs further research. But you do wonder about some kind of exposure.
Okay. I have a couple other questions kind of back to the screening. We talked about the mammograms, but it's not unusual for a woman to have an ultrasound. I guess the first question really is specific for screening purposes. Is that ever relevant?
Yes. Our society recommends that women who are normal risk, they be screened, obviously, with 3D preferable mammograms every year. But if you have dense breast tissue, you should talk to your physician about supplementing that with things such as ultrasound. Because we know that women who have dense breast tissue, that's where you're going to get your false negative with the mammogram. That's where you're going to miss something on the mammogram that could perhaps be picked up with an ultrasound.
Okay. And for some people to understand, a lot of times those tests are used kind of in conjunction each other to kind of, you might see one on the other and not on the other, and that helps kind of formulate what to do next for the patient.
Correct. They're certainly additive when used in a screening method. Obviously, if you have an abnormal mammogram, oftentimes the recommendation is for additional imaging like ultrasound to further evaluate that mammogram. But in terms of screening, they can give different information, particularly in a woman who has really dense breast tissue and where mammogram might be a little bit less sensitive.
Okay. This comes up a lot in primary care as well. What about the idea of breast MRI? When is that relevant?
Excellent question. It's interesting because the interest in breast MRI is different geographically. In Southern California, we were huge users of breast MRI. And I think, that can be a drain on the healthcare system. So I think it does need to be used judiciously. The patients that I consider using a breast MRI in are certainly patients who are at increased risk. For instance, patients identified with the BRCA mutation, or patients whose lifetime risk is much higher than the general population who have, for instance, dense breasts. Sometimes I'll alternate ultrasound with breast MRI in addition to mammogram. And sometimes we use it in challenging cases where mammogram and ultrasound don't give us the information we need. We will supplement at times with MRI.
Okay, and then you briefly mentioned genetic testing, because that is also something that comes up a lot for individuals.
Right. So women who have a family history of breast cancer, in the past, they would just be waiting for the shoe to drop. But in this day and age, we can actually test patients to see if they have a genetic predisposition and then be proactive. There are things we can do to reduce the risk of inevitably developing that breast cancer if they did inherit that particular genetic factor. So it's important to test people, if they have a significant family history, and even more importantly, if their family members that had cancer are still alive, to test those family members so we can see what's the particular gene that may be responsible for cancer in their family, and then identify whether the patient who doesn't have cancer inherited that gene and is at increased risk. And the good news is if they did not inherit that increased risk, they don't have, that family history no longer pertains to them. So you can exclude additional imaging in some of those patients where we exclude that they have the gene that's causing cancer in their family members. So it's a very powerful tool, and it has to be interpreted correctly in the context of family members with cancer. It's important to, carefully educate a patient what those test results mean.
And are you specifically referring to what's called the BRCA gene? Are there other genes that are tested for?
Yes, the BRCA gene was the first identified hereditary breast cancer gene. There's the BRCA1 and BRCA2 that if a woman inherits this gene and they haven't had cancer, their lifetime risk to get cancer could be as high as 80%. But nowadays, we've identified additional genes. And so when I see women and they have significant family histories, sometimes we will test for up to 84 genes that have been identified to be associated with hereditary cancer syndrome.
It's changing so much from my perspective, when I've been around long enough to remember. So what is a significant family history? How would you define that? I mean, I say to my patients, the closer the relative and the younger the relative, it makes it more significant. I mean, but some people have, an aunt who had breast cancer in her 80s, something like that. What do you think?
Right. So I think the number of relatives is important, and yes, the closeness in terms of relatives. But I also think it has to be looked at with a grain of salt. I always kind of quiz patients about 3 generations of their family history. Because, for instance, say mom was an only child or she only had a brother, sometimes that family history has to be really kind of teased out from prior generations. And so family history of breast cancer in multiple relatives, yes, particularly in younger age. And what's really significant, it stands out, is if someone was diagnosed premenopausally with breast cancer or had bilateral breast cancer. Sure. Another risk factor could be a family history of ovarian cancer, because particularly with the BRCA1 and 2 gene, ovarian cancer is at increased risk. And it's important to look at dad's side of the family too, because we used to think, and I learned in medical school, that breast cancer risk only came through the mother's side. But the reality is, as we understand genetics now, 50% of our genes come from our father, 50% come from our mother. So you have to go back and look at the females in dad's family as well as the females in your mother's family.
Okay.
Is there a significant risk to men, too, for breast cancer? And is there ever? I don't think there's any routine screening for men, is there?
There is no routine screening. And the risk, in women is 1 out of 8 women will develop breast cancer. In men, it's 1 out of 800. So the risk is much smaller in men, but it is there. And interestingly, male breast cancer is more commonly associated with hereditary syndromes because, for instance, the BRCA1 and 2 gene can be associated with an increased risk for male breast cancer. So men do need to be kind of cognizant of their breast exam when they're showering. If they feel lumps or have new symptoms, they should always bring that to their primary care doctor and discuss, and then additional imaging would be ordered. But yes, male breast cancer is real, and generally as a breast surgeon, we usually see several cases every year of male breast cancer, and there commonly is a delay in diagnosis because of the lack of understanding that these symptoms are significant in men.
We actually have to go to a quick break. I don't know how much time we have with you, but can you come back after the break? I have
Absolutely.
All right, great. Thank you for doing this. Welcome to the second half hour of this morning's show. Our guest is Dr. Lisa Curcio, who is a surgeon and a breast cancer surgery specialist, now practicing out of Rhinebeck Hospital, where we are developing a breast cancer program. And we have been talking about a lot of screening questions. And I did want to make a little editorial, but, in reference to COVID. It's really important that people not delay their routine care because of COVID. People should still continue to have their appointments and recommended screening tests. And I just wanted to say that as a primary care physician, to, not kind of gamble with one thing while you're worried about something else. Dr. Curcio, you still on the line?
I'm still here, yes.
Okay. We talked about screening, and we talked about breast cancer in men. We talked about when to start screening, when to stop screening, the role of mammogram, ultrasound, and even MRI, and also genetic testing. Just what happens if something is seen on a mammogram? What would you recommend? Go ahead.
Well, that's okay. So I think that, automatically people believe that once they get called back for an abnormal mammogram that it's going to be cancer. But that's not necessarily the case. Sometimes the patient will be called back and they'll do additional mammograms. Sometimes they do what they call magnification views, where they're looking for maybe little specks of calcium to see if they look suspicious. Or sometimes they're compressing out, because if you have dense breast tissue, you could sometimes get shadows on a mammogram that end up just being just shadows. And when we compress the breast more, then those shadows go away. And then sometimes we do additional imaging like ultrasound. And so sometimes after that additional imaging, everything clear, is found to be fine, and they go back to their yearly mammogram. Sometimes the recommendation will be maybe there's something there, but it's not worrisome enough to biopsy, so they'll recommend a 6-month follow-up. And then other times they'll say, we see something, let's do a biopsy. And again, a biopsy does not necessarily mean that there's cancer. In anywhere between 30 to 50% of biopsies, there will be benign changes, or maybe some changes that we need to follow, but not necessarily cancer.
Okay, interesting. And what are some of the causes of breast lumps or breast abnormalities that are not malignant, not cancer? Because these come up a lot too.
Right. So fibrocystic changes is probably the most common. We used to call it fibrocystic disease, but the majority of women have some sort of fibrocystic changes, and they could lead to lumps or abnormalities on a mammogram. Breastfeeding can sometimes cause calcifications to be deposited on the mammogram that'll be there. And so that's why it's so important to get the yearly mammogram, because you can look back and say, okay, these calcifications have been there for 10 years and they haven't changed. So we know that they're not anything of concern. Or on the other side, these calcifications have been there, but this year they're getting more significant or more worrisome, and hence, needing a biopsy. In the younger population, the most common cause of a breast lump is an entity called a fibroadenoma, which is an area of breast tissue that becomes mass-like, similar to like a fatty tumor called the lipoma. A fibroadenoma in the breast can create an actual lump that you can put your fingers around. And these are commonly seen in women in their 20s and 30s, and very benign cause that can oftentimes be followed as long as they're not growing rapidly. That's helpful to point out. So what if a woman does have a biopsy that comes back positive for cancer? What would be the next steps? So the next steps are for the women will be referred to someone like myself, a breast specialist, who would see the patient. And we're usually, as breast surgeons, the front line that kind of coordinates the care. So we evaluate them. As I mentioned, we do a very extensive family history. Once you've been diagnosed with breast cancer, there is a higher risk that you may have some genetic predisposition. So we decide if genetic testing is necessary. And at my office here at Northern Dutchess, we do genetic testing right in the office at that first visit. because it may affect the woman's risk to get a second breast cancer after we cure the first breast cancer.
Okay.
So that information early on is very important to get. And then we determine whether the patient is, what surgery the patient is a candidate for, and discuss those different options with the patient. So again, there can be shared decision making between myself and the patient in regards to what surgery we would want to perform. Not uncommonly, sometimes the tumor is bigger or more aggressive. So sometimes the patient will see the medical oncologist, which we help to coordinate, to determine whether or not maybe surgery shouldn't be the first approach, and sometimes chemotherapy is the first approach if it's a more aggressive tumor or a larger tumor that we want to shrink down to be able to do a smaller surgery. So all of that kind of is discussed in that first visit, and then we kind of give the patient a written plan. Here's what we know about your tumor right now. Here are the additional tests that you need to do. Here are the additional physicians you need to see. And then we regroup after a week or two to determine, okay, now what's your definitive plan? Are we going to do surgery first? Are we going to do chemotherapy first? And maybe you see the medical oncologist after surgery.
Okay, and I think the importance of team care is, kind of comes down what you're talking about to help with this, when someone has a diagnosis like this, using,
I absolutely. The breast cancer is one of the specialties that really requires what we call a multidisciplinary approach. And for instance, facilities like Nuvance, we actually have a multidisciplinary breast conference where we discuss cases every week. And there, the pathologist is there, the radiologist, the breast surgeons, the medical oncologist, the radiation oncologist. And in complex cases, we review the pathology slides, we review all the imaging, and then amongst all the different specialists, we discuss what's the best treatment management for this particular patient. So there's a lot that goes into that decision making to make the right decision, the individualized decision for that particular breast cancer patient.
Okay, I understand that, and that's good. And I think we are doing a good job of building a program and a team. Dr. Faisal Waheed is a local hem-onc specialist who recently joined Nuvance, and we also have in the Kingston Rhinebeck area Dr. Alfonso Coutinho, two oncologists, right? And then and then the team of radiologists and how important they are as well.
Absolutely.
Let's see, what was my next question? Oh, sometimes I hear stories about women getting kind of preventative or mastectomies, just having their breast removed because their risk is so high. What is your take on that?
So I think those are very individual decisions. I think that women who are at increased risk, I follow a lot of patients like that who have family history and kind of help them to decide what's the best screening modalities for them to have. And if they're found to have genetic mutations, we talk about what their lifetime risk is to have breast cancer. And I think it's a very individual choice. If they had women who had cancer in their family and they died of the cancer, sometimes they're more willing to be more aggressive with their preventative approach, like a preventative mastectomy. And in this day and age, reconstruction has gotten so good that preventative mastectomies doesn't necessarily mean that they're going to be disfigured for their life. We actually have excellent breast reconstruction surgeons who really reshape the breast and create, a very realistic breast reconstruction product that, sometimes it is very difficult to know that patient has had a mastectomy. Now, there obviously are changes that the patient will know, but in terms of the aesthetic effect, we can actually, in many instances, create very realistic looking breast even after a preventative mastectomy.
Okay, so it's a very individualized recommendation, but it's potentially something a woman would consider if her risk is high enough.
Right. There are other modalities other than surgery, though. A woman doesn't have to be trapped in that just as their only choice. We do know in women who are at increased risk, going on medications that we've traditionally used to treat breast cancer, that actually some of those medications have been shown in studies to actually prevent breast cancer in women who are at increased risk. So again, a conversation regarding what the risk is, how high is the risk, and whether or not the patient is willing to take a medication to potentially reduce that risk. That could be a very effective modality also.
So what medication are you referring to?
So the NSABP1 prevention trial actually showed that tamoxifen was 50% effective in reducing the risk of breast cancer in women who are at increased risk. And more recently, some of the trials, the P2 trials showed raloxifene showed a reduction in risk, which is Vista, which was initially an FDA-approved medication for bone density, so less side effects than tamoxifen. And some of the aromatase inhibitors have been shown to also be preventative for breast cancer risk.
Okay. All important notes. So we talked about a case where a woman may consider something, dramatic, like a preventative mastectomy. What about the opposite? Some stories of women who have a breast cancer they're sometimes told it's a nuisance tumor, or that it can be watched, or something along those lines. What is your take on that?
A nuisance tumor? I don't know if I've ever used that term before.
Okay.
So certainly, in an older population, in a patient who has a lot of medical, say, comorbidities, we sometimes don't take those patients to surgery because the risk of surgery could be higher than the benefit. And so if that tumor is, for instance, hormone sensitive, that means it's being driven by estrogen and progesterone, we can treat that tumor medically. But maybe what you're referring to is maybe some data looking at patients with non-invasive breast cancer,
Sure.
DCIS, which stands for ductal carcinoma in situ. And those patients, there is some controversy whether all of those non-invasive cancers would potentially become invasive cancer and whether or not they can be observed. I think that's a very controversial area. And certainly it's a conversation that I have with our patients who have DCIS, non-invasive breast cancer. We call it stage 0 breast cancer. But in general, we like to at least surgically excise it, and sometimes we do consider radiation. We certainly know that people who develop this non-invasive cancer are at higher risk to develop subsequent cancers, so they do need to be followed very closely.
Well, I think, that's exactly what I was referring to when I used the term nuisance tumor. The DCIS.
Yeah.
And these are things from a primary care point of view. I'm kind of like, and it's happened though. I have had patients come, they go down to various locations like in the city, and they've come back with the recommendation that it can be left alone and just monitored. And then that's I accept that recommendation, but it's good to hear you kind of advocate for. Seems like you lean towards having that removed rather than just observing it.
Well, my experience is that sometimes patients, with this observation, they kind of like, I had 2 mammograms and it was stable. So they just fall off and then don't do imaging for a while and then come back with an invasive cancer. Right. I think that's a big loss for the patient because now you're dealing with a potentially life-threatening disease versus DCIS or the non-invasive cancer. The cure rate is 99 to 100%. So why allow it to get to that point when you're dealing with a more serious disease?
Right. Okay, good point. I have some women who choose to get, instead of mammograms, they choose to get something called breast thermography. Is that something you've heard anything about?
Oh, yes. Thermography was very popular in Southern California. People are always looking for ways to avoid mammography because there's this concern that the radiation of mammograms causes cancer. But the reality is the radiation from a mammogram, is probably no more than an afternoon skiing and a mountain. It's really nowadays very negligible and less than a transcontinental flight the radiation you would be exposed to. Thermogram is based on temperature, and I don't believe, I am not aware of any randomized controlled trials that show that thermography is good at screening for breast cancer. I think it comes with a lot of problems because you have a patient who comes to you with just a thermogram, they haven't had recent imaging, and then you do a mammogram and it's completely negative, or an ultrasound, or even an MRI sometimes, and it's completely negative. And it's created all this anxiety, and there's no way to act on that thermogram. So I think it needs to be taken with a grain of salt, and I don't think in any way it replaces standard imaging of mammography.
Good points. I really discourage my patients from choosing to have that done instead of a mammogram. But it's sometimes people, they read and they get things in their heads, and it's hard to disavow them of what they already have decided to believe.
So, Doc,
sometimes it's hard to argue with Dr. Google.
Often here locally, there's difficulty getting patients to stay local when faced with a diagnosis such as this. We often talk about on the show, the high quality of medical care that's here, right in our midst. Of course, it's always great to get a second opinion, or we have such great, places like Sloan and places like that are, but the instance of someone going to a specialist and then coming home and then having an issue
Right.
Arise where they would have to travel long distance to actually, touch base with that doctor. I mean, Doc, how would you encourage our local patients to? I know it's a new program at Northern Dutchess Hospital, but I know we have excellent breast surgeons, doctors in this area. How would you encourage someone local to stay local?
Right. And I think that's part of what we're trying to do now with our program. I think people, it's important for them to know that we do have high quality care available to them here in our community. I think that, you go to those ivory towers, and I practiced in the community when I was in Southern California too, and I can proudly say that every community setting that I have been involved with, we provide optimal care for our patients, equivalent to what they would get at some of those ivory towers at the academic institutions. I think the difference is that we are working with their primary care doctors. They are, we're not seeing 1,000 patients a month, and so they are not a number. They are a patient when they're seen by us, and they call, and we answer the call, and we address their concerns, and we deal with them in their environment and provide a level of care that is really almost like a concierge type of care. It's individualized to the patient, and that you will not get at an academic institution. Now, if there are trials available we do have trials, I think as a system, we really do believe, and we have worked very hard at providing quality care within the community that is really personalized to the patient.
Okay, I'm a primary care doctor, and this is also my radio show. I mean, I really encourage patients to get their care locally. I've had patients, not specific to breast cancer, but something's going wrong at 4:45 p.m. on a Friday afternoon, and literally the instructions from the specialist is to call the primary. And the fact that I like when we all work together. I know my colleagues, and I know what type of care they're getting. So I encourage people to really get their care locally, unless it's not an option, which is understandable. People do have rare cancers or rare diseases or whatever. But other than that, there's no substitute for good quality local care. And that's
in terms of second opinion, I strongly encourage a second opinion if a patient wants to get a second opinion. Sometimes it can become confusing to patients, but I have all the confidence that what I'm recommending to the patient would be recommended by any reputable physician if they got a second opinion. So I think in many cases, it just solidifies the fact that they are getting that good care, but they're going to get the individualized care, and they're going to be in their community. We're going to be working with their primary care doctor to really, take care of the whole patient and not just the breast cancer, because sometimes there are a lot of psychosocial issues that come into play with the treatment of breast cancer, and those need to be addressed too to get the patient through treatment.
All good points, and it's a general rule that a good physician is okay with second opinions. It's part of what we do, and we're, if someone, as a primary care doctor, sometimes I'll refer the patient, and the patient will literally say, "Well, what's that doctor going to do for me?" And I'll say, "Well, they're going to either agree with me or disagree with me. Either way, I need their opinion." So it's okay, and then people should understand that. But that being said, if care can be given locally, it really should be. It's just the best way to provide to take care of people. Too many times I've seen stuff kind of fall apart at bad times. And actually covering admissions over at Northern Dutchess, it's very common for people to come in with cancer-related problems, fever from chemotherapy, or whatever problem, and their surgeons are 100 miles away, and they're specialists, and it makes it much more difficult to take care of them. So I encourage people to get their care locally.
So how can you get in touch with the, is there a new breast center at Northern Dutchess, or is there, how do we get in touch with
Is there a title there, Dr. Curcio? Or is it just, we always name things. Is there a breast center at Northern Dutchess Hospital yet, or is it not given?
Absolutely. There's a Dyson Breast Center at Northern Dutchess. So in terms of imaging, yes, there is a breast center with 3D mammography. And that's the other thing patients really need to know, that all mammography is not created equal. And so if they're getting their screening someplace that is not 3D, they're getting less than what would be considered state-of-the-art imaging. And therefore, either a cancer could be missed at its early stages. We believe we have state-of-the-art imaging at our facility, and we encourage patients to try it out, because I think the women who work in the imaging center are caring, compassionate, and they walk patients through every step of the way.
What do we have up at the Kingston Medical Mall? I know we have, mammogram.
Same thing.
I'm sorry?
We have 3D mammogram,
Okay.
We have ultrasound, and we have breast MRI. We don't have, right now, we're not doing biopsies at Kingston.
Okay.
But so they would be referred to the hospital for the workup of anything abnormal. But we have all the screening modalities at Kingston.
Okay. So important to note, I talk to my patients all day long. Please go to the Kingston Medical Mall for your labs, for your testing, because it just makes it so much easier for me to get the results in a timely fashion. And I appreciate that. There have been many, many times where people have gotten mammograms at other facilities that have not arrived, and that's very unfortunate. So I'm encouraging people to use the facility up at the Kingston Medical Mall. Let's see, we have a little time left, and I appreciate so much having you do this. I was just trying to think of some other examples of reasons someone might go to you. Men, as they get a little bit older, sometimes get a problem where they have developed some breast tissue, right? It's called gynecomastia. Is that something that you would work up, or would you send that to a plastic surgeon, or what do you think?
So we do see patients with symptomatic gynecomastia. A lot of men will develop gynecomastia as they get older. It's related to falling testosterone levels. But some of them have, maybe like gynecomastia on one breast and not the other. So it might seem like it's a breast lump. We see patients like this all the time. We see young men with gynecomastia, particularly as they're going through puberty, or some men as they're using different products to, say, build muscle mass. Sometimes we do see symptomatic gynecomastia. And not all of it needs to be surgically managed. And there is an endocrine workup, particularly in an older male, that needs to be done to try to figure out what the cause is. Sometimes it's related to medications. So we see that. in men. We see breast cancer in men. And sometimes men who have family history that are concerned about male breast cancer because maybe they had a relative with male breast cancer. So those would be reasons that we would see men in our office.
Yeah, I was two things that I would bring up is marijuana use, particularly in young men. And then as we talk a lot about the business of healthcare these days, because they took something called Zantac or ranitidine off the market, then we tried to prescribe Pepcid or famotidine, and now that's limited in supply. So we're kind of being pushed to prescribe something called cimetidine, which has a very clear side effect of causing this problem. So that's it's gotten a little difficult. Anyway, we're basically going to come up to a break, but it's been excellent to have you on the show, and I am thrilled to have you as a colleague and a resource for our community. Let's see, should we give people a phone number if they want to call? Although I do recommend that people get referred, but that's okay. I mean, whatever care people need, they should get. So what is your phone number at the breast center at Dyson at Rhinebeck?
Actually, patients can seek me out and actually call if they're having a symptom. My telephone number is 845-871-3108. And we do have what we call same-day appointments. We can see the patient. Say they're having a new symptom. We can see the patient, and we have slots at our breast center dedicated to our patients, and we could potentially get imaging that same day so that by the end of the day, they would have an idea what was causing their symptoms. And we feel like that helps the primary care doctor.
Absolutely.
Kind of taking it off your plate. And it also helps the patient to get an answer sooner because sometimes it could take them 2-3 weeks to get through the system once they have an initial symptom.
It's so important. So I appreciate that so much. Anyway, thanks for coming on the show. We appreciate it, okay?
Thank you for having me.
Okay.
Thank you.
All right, take care.